him to take over the.
Thank you, Dr. Sivakumar, and thanks to the Psychiatric Rehab Services in Nimhans for having me here to chair this program. And it's my very pleasant and happy occasion to introduce Dr. Kalyanasundaram. Now, Dr. Kalyanasundaram and I have known each other for more than 40 years. He was a faculty at Nimhans in the Department of Psychiatry at Nimhans, Bangalore. And after he has left Nimhans, he went into private practice. And then I think for more than 25, 30 years, he's been associated with the Richmond Fellowship Society India, especially the Bangalore branch, for which he was the CEO and secretary for many years. Dr. Kalyanasundaram has got many years of experience in managing rehab services and also, of course, treating and managing chronic mental health. So I'm indeed very happy to welcome him to this talk, and I'm sure that this talk will be very useful for the many caregivers and family members who have joined in here. So over to you, Sundar. I think you have got about, I'm going to take about 30 or 40 minutes, and then I think...
Yeah, about 30, 40 minutes. Yeah.
Dr. Sivakumar told me that after that you have about more than
yes.
half an hour. Yeah. So he says we can go on till about 3:30. So over to you, Dr. Sundar.
Thank you, Prof.Mathew Varghese, and thank you, Sivakumar, and members of DPNR for inviting me for this program. I know you've been doing a wonderful service of running this event month after month, very relevant to working with people with chronic mental illness. Several of my staff and colleagues have eagerly looked forward to participating in your monthly programs. And thanks again for asking me to come and share with you about what Dr. Sivakumar wanted was how do we run this halfway home programs in Bangalore. To have Prof.Mathew Varghese as a chairperson is a delight. He says 40, I think we go back a little longer than that. We're both known as good friends and colleagues. And more importantly, Mathew Varghese also have been hands-on with our Richmond Fellowship programs. He was even on the board, both at the national board and at the Bangalore branch. An active member in this space. I'm very happy to have him chair this meeting. Can you share the screen? Can I click on share screen?
Yes, sir. You can, sir. You have been made a co-host.
All right. Can see the screen? Yeah.
Yes, sir.
Okay.
You can go to full slide mode, sir. Slideshow.
Got it?
Yes, sir.
Thank you. Technology, I'm always holding my breath until this pops out to make certain things do actually work. I want to talk to you briefly about what, mental illness, briefly 1 line, 2 lines, and then take you to what rehab program could be and what is that we do in Bangalore branch. And then we would like to hear from the participants, their views, from whom we can learn and exchange information and knowledge. So to let you know that Richmond Fellowship started in India in 1986, although worldwide Richmond Fellowship was started in 1959 in UK in a place called Richmond. Therefore, it is called the Richmond Fellowship. Many people think that we are in Richmond Circle, and we are not. They think we are rich, and we are not. We are an NGO who do not get any government funding at any time. We try to make ends meet with user fees and some activity to raise funds. We are part of the founder member of Asia Pacific Group. Therapeutic community approach is the core area of work that we employ. Dr. Mathew Varghese mentioned that we have branches. We have a national board in Bangalore, although the Bangalore branch was the first one to start functioning in 1986. Then the Delhi branch came in, then the Sidlagata rural branch, which was at one time part of Kolar district, now Chikbalapur district in Karnataka. We have a branch in Lucknow. So it's one of those organizations which have presence in several parts of the different parts of the country. In Bangalore, we run a halfway home, a daycare center, and the long stay home. Halfway home started in 1986. The daycare center started in 1977. And our long stay home, Jyoti House, was started in 1995. So mental illness can be chronic, especially chronic mental illness. We talk about schizophrenia, bipolar diseases, sometimes long-standing major depressive disorders. Here our emphasis here is about schizophrenia, because that's a disease that is often brought to the halfway homes for some kind of a rehabilitation activity or rehabilitation intervention. It's chronic, relapsing, and progressive. Relapsing because if you discontinue treatment, we're going to talk about it in a few minutes now, the very high chance of illness coming back again and again. And it's a progressive disease. It doesn't stop. Once it's on, it's a continuously progressive disease. It is up to us, professionals and family members and the stakeholders, whom we call patients, to decide and make sure that we do not allow it to progress. We will see how can one do it. Usually early adulthood onset, late teens, early 20s, disability across various domains. Unfortunately, for a common man, including the family members, the disability is often not visible, unlike physical disability, where a person's illness is visible, like if he's limping, or he's got a hearing impairment, or a person has a visual impairment. All of those things are visible. Therefore, people seek help much faster. We have a rule of thumb. 1/3 of them recover and function normally, especially if you catch them early. We have a term that we use in mental health, DUP, duration of untreated psychosis. The longer the duration of psychotic illness which is not treated, the greater is the problem of recovering. The earlier you catch them, it is possible to arrest the progression of the disease to a very large extent, and they can function normally back to school, back to college, back to functioning as a homemaker, or back to working in a job that you have had, an IT, architect, engineer, professor, you name it. 1/3 of people function with certain dysfunction, disabilities, and 1/3 remain chronically ill. That is the nature of the disease. No matter what you do, they continue to remain dysfunctional. The last two portion, that is the last 2/3, that is 1/3 of the with disabilities, chronically ill. These are the people who will definitely require rehabilitation as part and parcel of their recovery process. This is one of my favorite slides. Those of you who have listened to me in the past would know that I repeated ad nauseum. I wanted to pay particular attention to this. This axis has got 100% full functioning of the individual, 100% at one point in time. Here on this axis below, you have the age of onset and progression of the disease over the years. If you look at the illness starting at say around 15 or 18 or 20 years, illness begins slowly, and suddenly the person has what we call the first episode of a psychotic illness. During that phase, the functioning of the individual, which has been nearly normal, drops to, let's say, 60%. That is, the person is unable to function, is functioning only at the 60% level, because the illness eats into the brain, disturbs the brain, and makes the person non-functional as a normal individual. Let's take the fact that he or she is taken to a doctor, taken to a psychiatrist, and medication is instituted. If you notice, the response can be pretty quick. Within a matter of 6 months to 1 year, the person responds well, and it starts getting better, and he goes back to functioning about 85 to 90%. Now, I want you to notice this point. You catch them early, start treatment, you are able to get back to near normal functioning, not fully normal, but near normal functioning. We will soon see why it is not near normal. Now, at this point in time, complacency sets in. I am better. I don't need medication. Even to start with, they don't want to come to take medication. They have to be coaxed, cajoled. Sometimes some kind of a methods are employed to see that the medicines are given to him. And once they get better, the patient or the family members feel, now that you're all right, you don't need medication. This is despite doctors cautioning, do not discontinue until we discuss this issue. But they abruptly discontinue the medication, and sooner or later, they have a second episode of a relapse. The question is, will he have a relapse? If the diagnosis is correct, the diagnosis is schizophrenia, the chances are very, very high. Almost everybody, 90-95%, if not all of them, will definitely have a second episode. If you look at a second episode, from the 60% functioning in the first episode, second episode, they function only 50%. And they are started to treat. And then again, if you notice, they take much longer time to respond. They responded in 3 to 4 months' time, they may take 6 to 8 months' time. And when they recover and they respond to treatment, they come up to a functioning of 70% and not more. And are they okay there? Are they holding on to the treatment? Are they maintaining treatment? Unfortunately, no. People have several such relapses. Every time there is a relapse, because the commonest reason for relapse is stopping medication. The second commonest is discontinuing medication. The third commonest is stopping medication. The point I'm trying to make is, as long as you're on a medication, right dosage, very likely that you can prevent a relapse. So multiple relapses, by the age 30-35, the person is actually functioning around 30-35% only compared to the first time before the illness, which is 90%. Over a period of time, they reach a stage of what we call treatment-resistant, chronic, relapsing residual symptoms. Patients, families often come during this phase for rehabilitation. My suggestion would be, you must catch them early for rehab, early, and not wait when the chances of rehabilitation itself becomes very difficult. Therefore, the emphasis here is start early, continue medication, do not discontinue, because every time you discontinue, you are going to find changes in your brain. You look at what is called a healthy neuron on the top. There are neuron fibers that are running with what we call spicules, which are little nodules on the nerve cell, on the neuron. These are the healthy neuron. What happens to the person with a schizophrenia? If you look at a person with schizophrenia, the same neuron, all those little nodules, all those little spicules, which are very essential for its normal functioning, they seem to have disappeared. This, when it progresses, causes brain damage. Once the brain damage happens, unfortunately, in some people, it becomes irreversible. We should not allow that stage to reach. To prevent that, as I said earlier, start early, continue treatment, do not discontinue until the treatment is provided through the period as a maintenance dose. Look at this brain picture. On the left side, normal adolescents. On the right side, adolescents with schizophrenia. They are boys and girls. You see the brain full of functioning, full of activity, full of energy, all in blue and green pattern, which indicating normal, healthy, active brain functioning. You look at adolescents with schizophrenia. These are the people who start their life early, unfortunately, with schizophrenia disease. You have various grades of this is annual loss of brain substance. 0 loss, 1%, 2, 3, 4, 5%. You can look at the various colors indicating different parts of the brain seem to get affected by the disease. If you don't take treatment regularly, if you don't remain healthy, then this progression continues and multiplies. And not many areas are spared. Depending on the area of the brain that is involved, then you start hearing voices, you start seeing things, you become suspicious, you laugh to yourself, smile to yourself, you do not obey family members when they tell you something good for you, you start becoming destructive, become aloof, you lock yourself in the room, you don't want to meet people. All of it is not because you want to be there, the brain makes sure you remain in that state. Therefore, brain disturbance or a damage, the extremely common phenomena, happens in all people with schizophrenia. Our job is to make sure we do not allow this progression to take place. So what does rehabilitation mean? Psychosocial rehabilitation. That's the definition which is often quoted, the WHO definition. You can read it for yourself. Provides opportunities for persons who are impaired, disabled, and handicapped to reach optimum level of independent living functioning in the community. What is optimum is variable from person to person, but rehabilitation aims at providing that opportunity for you to reach that level. Remember, you have got a disease which you did not invite to yourself. It has happened to you. You did not know it's going to come. But part and parcel of the nature of the disease is you do not realize you have a disease. You do not believe you are ill. Professionals call this lack of insight. When you are lacking in insight, you don't believe you are ill, therefore you won't take treatment. Somehow the treatment is offered. If it is good and beneficial to you, we must make certain that the treatment is continued, then you get out of that ill state towards getting to be a wellness state. So what do we do? Some examples of what we do in Asha Halfway Home. It's a residential facility. It's situated in Jayanagar, in an area where surrounded by other families, other houses. It started in 1986 in a small place. It is now currently the RBI colony in JP Nagar. Some of you are familiar with that topography. You might remember that. Started in 1986 there in a mud facility. Somebody donated us a place. It's a asbestos roof, mud building, bunk beds, 8 to 10 male residents with one kitchen and one toilet with a tin facility. That is how we started, 1986. 1988, 89, we moved to Jayanagar after we acquired a house there, which got modified to suit the needs of rehabilitation. It offers a friendly, caring environment and importantly run by professional rehabilitation staff. I believe any functioning of any program, any good running of a program, the infrastructure is very important. Infrastructure can be in terms of your building, your rooms, your office space, the rooms for the clients, kitchen, open space, maybe play area, some place to relax and spend some quality time with your other peers there. Even more important is the infrastructure to me, the kind of a staff they employ in the rehab programs. The first contact with the person who picks up the phone and say, hello, good morning, good afternoon, Richmond Fellowship. Now, that is the starting point of a good connect with the family, which to me is an extremely important component. We serve the need of people diagnosed with mental illness, who we offer them stay between 6 months to 18 months. Average stay is about 12 months. It is designed to help clients develop a sense of responsibility, accountability, and we offer both individual family therapy, group activities, and vocational training, particularly the daycare center, which we were running till COVID struck us. It is a temporarily closed We hope to restart soon because we needed some minor repair work which is going on now. Vocational rehabilitation is a part and parcel of component of any rehab activity. So what are the objectives? Reducing symptomatology. That means the first thing we do is to make certain, is the patient on regular medication? Is the person adherent to taking treatment? Are they actively symptomatic? Are they abusive, screaming, shouting, grossly deluded, acting on their paranoid symptoms? They are destructive to the community, they are sleepless, or they have a tendency to wander or an escape. If those symptoms are there, we are not able to accommodate them because it is not a hospital. It's a rehab center which accommodates people whose symptoms are generally brought under control. What we call positive symptoms are brought under control. What we predominantly look at is people who have negative symptoms. Those who are aloof, not mixing with people, not interacting with people, lacking in initiative, lacking in any kind of a socialization or other activities. We work on reducing discrimination and stigma. Family support, social support is an extremely important component of working with people with severe mental illness because families are part and parcel of our active programs. They are partners in caring. Without family involvement, regular feedbacks, regular visits, we will not be able to progress because rehabilitation is tailor-made for individuals. We have a broad framework or a template, but individual needs are tailor-made for each person. So what are the things that we offer in the rehabilitation? Now, sometimes you will find personal hygiene. Many patients who come to us, sometimes they don't brush their teeth, they don't bathe, they don't change their clothes, they keep wandering up and down, mumbling to self. These hygiene, routine things that we take it for granted in our day-to-day activities seem to get destroyed by this disease. The disease destroys the regular functioning of the individual. They begin to believe, they begin to function in that space which are very distressing to them and much more so to the family members. So we ensure the personal hygiene is maintained. They are woken up in the morning, they are asked to brush their teeth, they are given some coffee in the morning, they exercise, activities of daily living is looked after. They're asked to bathe, sometimes they need to be monitored whether they're bathing properly. So all of those routine activities are actually restarted for these people under supervision. We looked at, we give them, sometimes we tell them to go to the shop and come after a few months of rehab for them to learn how to go and buy some things. Now, they may have done this in the past, but some of the disease seems to take that skill away from them. Give them 50 rupees, go buy your personal items and come back, give you an account. Whether you know to spend 38 rupees and bring back 12 rupees as a change. Are you able to keep an account of that? Are you able to buy what is required? Do you know how to talk to the shopkeeper? Initially, the clients are accompanied, the residents are accompanied by staff members. Later, they go on their own every week to buy their personal requirements. We make certain medication adherence is complied with. Some of them come and they have not been taking medication regularly. And that itself is enough to provide the disturbance in their behavior. So we make certain medicine is given to them every day. They are taking 2 times a day, 3 times a day, as per the doctor's prescription. We also make certain psychiatrists refer patients to us, different psychiatrists. So once they come to Richmond Fellowship, we request that the referring psychiatrist to continually monitor their treatment. That means we do not take over managing the patient except for rehabilitation purpose. So they are sent back to the treating doctor periodically as per the doctor's wish, maybe once in 4 weeks, once in 6 weeks, as and when necessary. Should they have a relapse, the same doctor is contacted, patient is sent back for the doctor to either, if necessary, admit or monitor treatment, modify medication, and send back. To make certain medication adherence is done, staff supervise initially, making them certain they take the medication, they put it in their mouth and actually swallow it. Sometimes they can hide it, behind their cheek and spit it out later. Over a period of time, we teach them to maintain their own medication. That means they prepare their own medication under supervision every week. So each patient's medicine is brought, the staff are there, they take the medication that they are taking regularly, put in their pill box and fill it up for 1 week under supervision. So they become responsible over a period of time, because ultimately they have to go home and they have to do it at their own place. Work behavior, time management, how to manage time. We have special skills, social skills training that is offered, taught by our senior psychologists used in our team to our staff members there, who offer social skills training for them on a periodic weekly basis. So what is the structure? There we have a president and a vice president. Secretary CEO is a person who actually runs the day-to-day activities, supervise the policies, implements the policies, have an overarching responsibility for the good functioning of the organization. And there's a treasurer who looks after the financial aspect of the fellowship. All these, of course, are all honorary position. I was the secretary CEO for 30 years. 4 years ago, I stepped down. Now my colleague, Dr. Aditya, is the treasurer. And there is a governing council. Governing council consists of people from different walks of life. There are architects, there are family members, there are business people, there are management consultants, and there are accountants. So we get people, family members being part of the governing council is an extremely important component in our organization. And they meet once in 2 to 3 months to provide the structure and policies for the organization, which is then implemented with the help of the admin officer. Then under admin officer functions independently with the accounts department, which is I have an office superintendent, account staff, and support staff like cook, attenders, and a security. The other wing is the rehabilitation team, that is the staff team. The minimum qualification with which people join us are MSW or MSc or MA psychology. That's the minimum qualification. And they start as rehabilitation counselors, as you see here, at that level. At the end of 2 years, if we find them suitable, after an internal review, they are promoted as deputy rehabilitation managers. At the end of 5 years, if they are suitable, and if they have shown leadership qualities, ability to train juniors, manage clients' problems independently, they then get promoted to level of rehabilitation managers. So we have a daily structured routine. You can read it for yourself. Monday, Tuesday, Wednesday, Thursday, Friday, 5 full functioning days. There's a group of activity in the morning. There's a group of activity in the afternoon. I mentioned about medication preparation. That happens every Monday. Then there's a community meeting. All the group members in the community, both men and women, they join together. There is a yoga class or a Zumba with music, social skills training I briefly touched upon. Yoga, music, and dance therapy on rotation happens on Friday. There are indoor games, quiz programs, recreation, puzzle, coloring, painting, laughter therapy, etc. Recreation can be in the form of going out as a group to have a snacks outside once a month, or to go out for a meal of their choice, nearby walking place, and once a month again, they go for a movie of their own choice. They decide, depending on which movie is running nearby, they go out as a group with some of the staff accompanying them. And once in 6 months, at least twice a year, we take them out on a picnic. Periodically, we also take them to visit some important centers in Bangalore, Lal Bagh, planetarium, other interesting things from where they can learn things. So every day, as I mentioned earlier, maintaining personal hygiene, exercise as a component of daily activity, planning meeting happens with the clients. Then all clients participate in what we call vegetable cutting in the kitchen, running 365 days, 24/7. So there is a kitchen and assistant staff who help. On the day of the morning, the cook decides what is the menu for the day, for lunch and dinner. So many clients, both men and women, sit together, about 10-15 people. They do vegetable cutting as a part of a group activity. And they do daily maintenance. They go back to the room and clean up the space. They have to clean their own rooms, clean their own bathrooms, and make up their bed. And once a week, the staff supervise whether they're maintaining their cupboards and things on a regular basis. Something like what we would do in our own home. We try to recreate the things that you would do near home, which you have not been doing, but you come here having lost those skills or interest. We recreate the scene for you to get engaged, so that when you go back, the same activities can be continued at home. We have a group activity, vocational training. In the evening, there is a prayer meeting, not affiliated to any particular religion. There's a silent prayer. You can choose to pray whichever God or somebody higher up that you want to pray for. How does admission happen? Referrals usually come from a treating psychiatrist, and the family members bring the referral form from the psychiatrist. Psychiatrist says, go to Richmond Fellowship. They're running a half-hour program. Go and see. So we take the family members. Sometimes they come alone first time, and then they come with the clients. Also, we take them around, show around the place, tell them what we do. In our center, each room has 2 or 3 clients in a room, all of them with an attached bathroom. First floor is for men. Ground floor is for women, 14 men and 9 women. Women have an independent common area where they have their own television, other music program for them. Men have similarly a common lounge where they would like to watch, for example, cricket or a football or whatever. Women generally watch the music program or a TV serials or a movies. We keep them on once they go around the facility, then they are given an application form. The application form is filled up and handed over. If there is no available admission, they are kept in what we call in the waiting list, and they will be called as and when a vacancy arises. Other important thing that we do is what we call a trial stay. When a new client comes in, the person is not admitted immediately. We keep them for about 2 to 3 weeks with us in what we call a trial stay, which means the patient is on a trial and the other residents are on a trial from the patient's point of view. What do we mean by this? We want to make sure the patient is able to acclimatize himself. The person is able to interact with our group, want to be part of this group. They participate in all the activities, all the programs with all the other clients. They get to know the names, they get to live with the people, they get adjusted, get to be with them for all the meals on time. That also gives us an opportunity to notice whether they have any active symptoms. Are they hallucinating? Are they very suspicious? Are they becoming aggressive? Are they sleepless and disturbing the rest of the community there? So the trial stay is given about 10 to 15 days. At the end of the period, we ask the opinion of other residents about what they think about this patient. What is their view about this? And this patient also wants to tell us how he or she is getting integrated. Then we have an admission committee. The admission committee is generally chaired and members are all from outside our RFS facility. And they are psychologists, social workers, or psychiatrists who are part of this team. They independently assess. The staff members by then have done what we call an initial workup about the patient. In spite of the fact they have been under treatment in the past, we start afresh. We take a complete intake interview, assess them, do a mental status examination, and then make a presentation to the admission committee. The admission committee will review the story, review the case, call the family members, talk to them, find out what is the requirement, what do they need, and then advise us what are the areas of work that we need to emphasize upon. Very often, the admission committee members are professionals who are outside RFS, psychiatrists, social workers, and psychologists, those who are in practice, or those who are from St. John's, or predominantly from Nimhans. And we have a MOU with Nimhans. Therefore, it makes it easier for us to work and interact with the professional team from Nimhans. Duration of stay is anywhere between 12 to 24 months, depending on the need. At the moment, we have 23 residents staying with us. The intake is about age between 18 to 60 years. We don't take children. We try not to take people with a very senior members beyond 60, 65 because they also have associated physical problem or associated comorbid conditions. We are not equipped to deal with it in our halfway home. Inclusion criteria, diagnosis, normally we take people with schizophrenia, chronic depression, bipolar. Sometimes we have had OCD or OCD as a comorbidity with severe mental illness. We do not take neurological conditions, people with physical disability, geriatric concerns, substance abuse, intellectual disabilities, not because they don't need help. It's because we do not have that wherewithal, or we do not have the skills to manage them in our place. Sometimes people with disability, physical disability, need an attender to be with them. We do not have the facilities to offer such opportunities. So to conclude, residents who stay more than 1 year, we found in our study had significant improvement. On admission, we do PAN scale, we do ideas, we do SOFA scale, disability assessment scale, and they are periodically assessed every 3 months. So we found out that if they stay for more than 1 year, they show significant improvement. Some of them do not complete the planned duration of stay. We have said 6 months to 10 months, 8 months, 10 months. Some of them don't stay. Why? They discharge on family's request. There's a wedding in the family. We want to go back to Andhra Pradesh. The patient is not suitable because the person is substantially symptomatic and we are not able to hold him back. They find a difficult adjustment. Some people do not want to stay. Family members cajole them, coax them, because we want them to cooperate. They want them to be willing to stay because we do not lock them up in their rooms. They are open. So we do not force them to stay if they do not want to stay. If they persistently say, we do not want to. In fact, we have had a couple of people escaping from our premises, which becomes a huge responsibility for the staff and the administration. And if they have frequent relapses, which requires medication monitoring, more frequent adjustment of the dosage, we send them back. With all this, many have been placed in job with the help of staff team and support of the family members. Many reported improvement in confidence, increase in self-esteem, ability to make decisions, and families and the patients have been, residents have been enormously satisfied. Because of continuous monitoring of medication adherence, patients over a period of time realize is actually important. This facilitates insight of the fact that as long as I take medication, I'm functioning. I'm like everybody else. I don't have the sick role that I have endured over 10, 15 years. So this helps them to learn to acknowledge the need and benefit of medication, therefore reducing relapses and reducing burden on the family, both psychological and monetary burden. Sometimes with intervention, we try and reduce tobacco consumption. It is something very difficult majority, my colleagues will agree, majority of the patients with schizophrenia, they have this addiction to tobacco, very difficult to control. We always want to say, remember, physiotherapy is very important for anybody with a bone injury or an orthopedic surgery. You had a fracture, you have injured, the doctor or surgeon has put in a plate and a screw. He does not say, go home and walk. He makes you walk. He engages a physiotherapist who helps you to regain your mobility, your strength, and strength in the muscles, which have become non-usable, let's say, for 2-3 months. Without physiotherapy, you are not going to get your functioning back at all, despite the best of surgical skills. We agree and admit everybody with an orthopedic injury needs physiotherapy without fail. Why is it not for psychosocial rehabilitation? Why our people with chronic mental illness, severe mental illness cannot and should not be offered physiotherapy? In my opinion, they must, and we should provide rehab services, because we cannot just rely on medication at some point in time. We need to move on to the next stage. Medication and rehabilitation is a perfect combination. Now, some of you may have seen this slide, this 2 minute, less than 2 minute slide. This is one of my favorites, to let you know this disease is not something that we invite ourselves. Just see this clip. Thank you. The point I'm trying to make is this is a real story. It happened in a place called Zanzibar in Africa, but it happens everywhere across the globe. About near you, somebody known to you. They don't want to be sick, but they are sick. They did not invite the disease. We have to be sensitive to the fact this illness is not invited, but they are treated and isolated as if they invited the problem and they need to be abandoned. I think we should move beyond and make certain that every stage in our lives, we provide the best that you think that your family member will deserve. There should be no difference to who comes and seeks their help to you with hope and confidence. Thank you.
Thank you very much, Dr. Kalyanasundaram, for a very comprehensive presentation. Not only did you mention different aspects of the illness and how it's important to have people take treatment, go regularly to the doctor for treatment. And also you covered different aspects of rehabilitation. And in some detail, you covered about what happens in a halfway home and the usefulness and the need sometimes for people who have got a little more chronic illness to go to a rehab. So I think I would ask, there are more than, I think at one point there were more than 130 people here. So some questions are there in chat and we have enough time, I think more than half an hour for questions. So I'm just going to try and take some questions from the top.
Can we stop the screening? You can remove the...
You can stop screening, stop the screen.
Stop share, huh?
Stop share, yes, please.
Oh, thank you.
So let me just look at the questions. Maybe Sivakumar and others can also help me with this.
Yes, sir. The first question is from a person, I
so
think.
Somebody asks, are you helping the UID card, UHID card, I think they mean. Probably Sivakumar can answer this, isn't it? UHID card, I think
It is
the
UDID,
RFS
sir.
doesn't provide.
UID card,
UDID,
yeah, yeah.
sir.
UID card.
Yeah. We try and help all our clients get the UID card. In fact, Sivakumar and his team at Nimhans have been very, very helpful. And we make certain all of them get it because they all deserve to have their unique identity card. Yes, we do help them. Yes, we do, Matthew. We do.
Sivakumar, you want to add something to the UID issue?
UDID is the unique disability identity card for those who are unaware. And mental illness is one of the disabling conditions which is included under the Rights of Persons with Disabilities Act. So for a person who is disabled with mental illness, there are gazetted instruments by the government called IDAS, Indian Disability Evaluation and Assessment Scale. We administer the scale on the patient and then we get a score. And depending on the score, we can categorize whether the person is disabled or not as per the Government of India guidelines. Please remember that every person with mental illness is not disabled. Like people may be disabled temporarily with medications, they may become better. But a fraction of people, as Dr. Kalyanasundaram mentioned early in the presentation, 1/3 recover, do well, 1/3 have a relapsing kind of a course, and 1/3 actually are disabled and then they have do not have a very good kind of. So the UDID card actually helps in people where the mental illness has actually caused disability in the patient under self-care, interpersonal relationship, communication and understanding, and in the work domain. That's all.
With the UDID card, you're able to get some benefits which the government provides and some concessions with regard to education, with regard to jobs and so on. So, but remember that it has to go to the, there's a committee that is formed which sort of certifies, and then you get an ID card, which is the UDID card. There's another question which says, I hope RFS Bangalore arranges occupational therapy, of course, for people to get back to their jobs. I think Dr. Sundar mentioned this. Sundar, you want to talk about this?
So, in fact, I think we were one of the first ones in a private sector to offer vocational rehabilitation, along with the psychosocial rehabilitation and the daycare center, which you ran in called Chaitana in NR Colony. I think Matthew Varghese was very much part of our team in those days. It's a very successful program. You would get about 50 people coming every day from their homes, including about 15 or 20 who would come from our own programs in halfway home and long stay home. They would come in the morning around 9:30 and go back at 4 o'clock. We had a bus that would pick up some clients from south of Bangalore. Very successfully run program, which also included our green scaling program, with which Nimhans and we have collaborated for a number of years. Very successful. And unfortunately, COVID struck and we had to close down, but we are hoping to restart very soon. There's a lot of demand for this. I think occupational therapy or vocational rehabilitation, an extremely important component of getting them back on their feet. And several of them, having worked with us in rehab center, have gone on to either take a job, or we have facilitated them to help take a job, or they've been able to run independent program from telephone booth, Xerox machine, or doing photocopying and other related programs they were able to run. So I think it's an important component. I think it's very necessary for all patients with chronic mental illness to go through rehabilitation at some level or other, for certain.
Also important to remember that RFS and MPA and other organizations also, once they go into a program, once they get a job, they can come back and get support from the rehab center and also the mental health professionals who they work with. So I think that's very important.
Correct.
Is to get support subsequently, because as you go along in the job, as all of us know, there'll be different pressures that people have to face. So to learn to cope with these things, that's something that is an ongoing process. There's another question saying from Padmini, do you take legal guardian to those for single child? I don't understand this question. Does somebody want to answer this again? Ask us again. Somebody called Padma, I think. Right?
Rajeshwari, sir. Ms. Rajeshwari.
Yeah.
Ms.
So
Rajeshwari, can you unmute yourself?
Legal guardian for a single child? I don't think any of them takes on the legal guardianship role.
Correct.
For temporary period while they're in the home, they are obviously you are their guardian, but not for a lifetime. Sundar or Sivakumar, you want to answer this about legal?
In fact, when it comes to these kind of matters, we turn to Dr. Sivakumar and his team because they're also part of our board members, and they have a lot of experience in Nimhans about providing this kind of a legal support and help. Sivakumar, would you like to throw some light on this issue?
No, I think RFS as a organization does not take up legal guardianship for the persons. It only provides temporary care. So it is a halfway home, halfway between the hospital and the community. That is what it is. The procedure for legal guardianship is totally different. And just for your information, as Dr. Mathew informed you about various benefits, we have posted a pamphlet on welfare benefits which a person disabled with mental illness can avail. It's available on the chat box for those who are interested.
Dr. Sundar, would you also want to mention about people who are in long-term care? I don't know if this refers to that. There are some people in long-term care, isn't it?
Yeah.
More than 2-3 years.
Yeah, okay. That's a good point, because we also run, as Dr. Mathew knows, a long-term care called the Long Stay Home, Jyoti Home, which was established in the year 1995, which means we've been functioning continuously for the last 27 years. So people have come in at a middle age, 35, 40, 45, they have now become 65, 70. As they grow older, they have comorbid physical problems, arthritis, some people with cancer as a comorbid condition, eye problems, sometimes cardiac problems. So we try to support as much as possible. The family members execute a support to us saying that so-and-so will be the legal guardian of this individual as long as they are alive. If they are not there, they nominate someone else, the legal guardian, who usually is a other family member, a sibling, or a close relative, or an uncle or an aunt, who are physically and mentally healthy at this point in time. So this kind of an undertaking we take for those who are with us. Those who are with us in the long stay home, they stay with us for several years with us. In fact, Dr. Sivakumar has been our chairperson of the long stay home. So this facility is different from the halfway home, where people stay with us for a period of 18 to 24 months. And then the target for them is to go back home and not stay with us.
I think that's very important, because as per the new Mental Health Care Act, just want to impress on all the carers that every patient who has a mental illness has a right to live independently in the community and not really be in a halfway home or a long-term care home. So as far as possible, we try and see whether they can stay in some house outside with support from other people. Even if their relatives and guardians are abroad or other places, we try and see that people who are functional can actually stay in flats or homes around these mental health facilities so that they can be supported. So I think that's very important. There's somebody who asks, somebody called Divakar, who asks, at what stage is the gray matter in the patient present, and is it possible to monitor the change over a period of time?
Well, the gray matter is such a minute change, but a very definite change. It is not something that is picked up in your routine scans and MRIs. It is something that has been established by scientific studies. On the routine scales, you cannot. But we know for sure this further worsens and deteriorates. So we have to catch early, maintain. People often ask, is there a cure for this disease? I ask them, is there a cure for diabetes? Is there a cure for blood pressure? A cure for thyroid disease? Is there a cure for cholesterol? The only thing medicine does in curing is curing infections. All other conditions are long-standing conditions. We bring them under control and we maintain them to stay stable. Similarly, it is possible to do that with mental illness if we catch them early, arrest it, and maintain the illness, maintain the recovery at that stage with all possible support, medication, family support, maybe long-acting injectable sometimes, and rehabilitation where and when necessary. I think that is what we should be aiming at.
So as Dr. Sundar mentioned, an MRI or CT scan is not required to make a diagnosis, nor is it useful to see whether the brain changes occur, because these changes are not really seen on an MRI. So that's not really something that, it's just something that is scientific and academic. It's not important really in the practice. So there's another, somebody said, how do you spread the message regarding advantages of halfway homes in the community? Good portion of population have no idea about it first. And secondly, they don't want to send their family members to the establishment with stigma. So I think that's very right. You will know about a halfway home or a rehab center only once you go to the mental health professional, who in the process of treatment, they will always tell you what rehabilitation involves and what you must do to go to, facility. And as Dr. Sundar mentioned, it is only this latter 1/3 or 2/3 which might require this going to a halfway home or a long-term facilities. Average duration of stay, somebody's asked, Dr. Sundar already mentioned it's about a year. And if it's long-term care, it might be more than 2 years. Are the patients allowed to keep a mobile phone, during the day? Yeah, I think, Sundar, you want to answer this? I know.
Yeah, in fact,
what
more
happens
and
with mobile phones.
In fact, initially, I remember when mobile phone came in, we were rather strict about non-use, but we realized all family members want to be in touch with them. But we have certain restrictions in our center. We do not allow them to keep mobile phones 24/7 because they tend to spend time more and more. Some of them get into social media. We have had patients who have got into trouble by becoming friends with social media and then landing in big problems. So sometimes we need to monitor that. So we allow them the use of mobile phones for about half an hour or 1 hour a day at designated times so the family members can call them, chat with them. Otherwise, we take it away. If they want to use, we also allow them the use of computers. We give them time every evening for about half an hour to send mails or connect with their family and friends. All these are done under monitoring. Sometimes they get into the sites which are not very healthy. So when we do come across, we try to block those sites for them and make certain that they do not land in further trouble, in addition to the mental illness problems. So yes, we do permit, but under certain conditions, yes.
Yeah, I think this is what happens. What Dr. Sundar said is what happens in most rehab centers. The person does not keep the phone 24/7 because that doesn't help with daily activities. And of course, having mobile addiction is not a good thing. So they're definitely contact with the family and contact with the outside world is very important. But there is a restricted time for us. For all of us, there's a restricted time. So similarly, patients also have to learn that they have a restricted time and they will use the mobile or the internet and what they need to see. Another question, can you say some more about models of rehabilitation? And added on to that, Sundar, is another question on, can you mention more about the remission part of the illness? So first models and then remission. Well,
different organizations use different kind of models. We follow what is called therapeutic community. Some people will follow a model called token economy. So each of them have a very specific plan of utilizing certain specific methods of coping with people with requiring rehabilitation. End of the day, the goal is for them to function better, normalize as much as possible, at the same time work with the families. Remember, in a halfway home, the goal is once they get better, they go back to the families. If the families had been dysfunctional, some of the families are. If they go back to the dysfunctional family, the chances of relapse is pretty high, despite the fact they are on medication continuously. Therefore, our aim is to not only work with the patient, also work with the families to make certain they understand the disease better, they understand better coping mechanisms, their interactive pattern, if it had been faulty, needs to be corrected. It's an ongoing process. Rehabilitation is a journey which has not an end point. It's an ongoing process. So all the cardinal stakeholders, the clients, that is residents, family members, the staff, community members, are all part and parcel of the same journey. Everybody needs to work together, collaborate together. Sometimes, like the train halts in a place, rehabilitation can come to a standstill point. But we can still move on. So we have to make sure that we do not lose the positivity approach and keep moving on and make them functional as much as possible.
So I don't know whether the person who asked it wanted to know about models and settings. So as Sundar mentioned, there are different settings also.
Settings, yeah.
There are daycare centers, there are halfway homes, there are quarterway homes, there are long-term care centers. There can be partial
hostels,
hostels. There are different kinds of settings. And of course, Dr. Sundar mentioned that there are different theoretical models that can be used to in the treatment, in the therapy that you do in the halfway home. Some more questions. If you're sending patients with the boy or girl for admission, are the parents allowed to stay for 2 or 3 days? I think Dr. Sundar mentioned that there's a trial stay. In some places, I think, I don't know, in Richmond Fellowship, are they allowed to stay? The parents allowed to stay for a few days in the rooms close by?
They have been staying with the parents for 30 years.
No, I'm saying when they come to the halfway home.
No. We do not generally allow the family members to stay with the clients when they come in for a halfway home. But sometimes the parents are very anxious. They come every day to see, is he eating well? Is he sleeping well? Their anxiety sometimes does not allow the patient to get away from the family and begin to live independently. So the anxiety also, so we need to work with the patient and parents and say, if you do this, what is likely to happen? The same pattern has been established for 10, 15 years. So we need to make this separation very gentle, gradual, with clear understanding about why we are doing what we are doing over a period of time. This works to the advantage. But as a matter of policy, we do not allow parents to stay with the clients within the premises during the trial stay. Yes, we don't.
Yeah, I mean, I think as Sundar mentioned, because of the anxiety, many parents might actually
Overprotection.
Land up staying outside for some time just to see that their son or daughter has adjusted properly. I know in homes like the Medical Pastoral Association, they're allowed to stay for a couple of weeks till the adjustment occurs, until they go away after the trial period. Some question about if somebody refuses to take medication, what techniques do you apply? And then there's another question again, which is related about consent. Do you take the permission of the patient to be admitted? Or, if they refuse admission, what happens?
Okay. If they refuse to take medication, what do we do? I think this process has already been gone through by many family members while they have been under treatment over several years. Different doctors, different psychiatrists do different methods to make certain the medication compliance is ensured. One of the common methods is to give them long-acting injectables. So these things have already been done before they come here. After coming here, some of them, they say, we will not take medication. But to our great surprise, when they see all of them queuing up at 7 in the evening, at 8 in the morning, queuing up to take medication, they seem to feel they are being left out. They slowly, gradually join the process and begin to take the medication and become very adherent and compliant. So this transition takes place by looking at other peers, being there together, living together as a group. In fact, we have seen some of the patients who are living with us, staying with us, explaining to them why they were not taking medication, what did they go through, why are we taking medication today, and what benefit I've had. I want you to try and take it. When they hear it from their other fellow peers, they seem to take it better. And they help them and say, I will bring you water, you swallow the medicine, I will stay with you. If there's any problem, I'm with you to take care of you. This gives them a lot of confidence. And more often than not, we have been successful with that. Yeah.
Yeah, so the simple question is that nobody is kept in the halfway home without their consent.
Yeah, absolutely correct. They have to
You
give their consent. Yes.
they have to give their consent because,
Yeah.
like Dr. Sundar mentioned, most halfway homes are open. At any point in time, they can actually just leave and walk out. Of course, we coax and cajole them to stay
Yes.
and explain to them why it's useful to stay. But if somebody insists, as Sundar mentioned earlier on, if somebody insists that they want to go home again and again, we
can't keep
make it a
them, yes.
point to send them off. We can't keep them against their will. Another question is about, so do caregivers in halfway homes get any training? So as Sundar mentioned,
Yes.
carers are not really admitted into the homes, but when it's time for them to go home, when it's time for these patients to go home, then the family caregivers are called and given some advice, education, and training to see that they can get adjusted back at home. So in some ways, sometimes you might have to do a kind of slow trial stay or return back to the homes. And the contact with the caregivers is very important for them to also learn how to look after these persons when they come back to their homes. So they want to add anything else to that?
Well, I think I completely agree with you. In fact, we call them every 3 months, 6 months to make them see what kind of progress their son or a daughter or brother or sister have made. We want them to see what's happening. Sometimes when we had the facility to keep them here, the family members would spend 2-3 days with us and be part of our activities on a daily basis. When they realize that the people can actually get better and they become a little hopeful, then we sit and teach them as to how they should handle them when they come back. What should they be doing to make certain they are welcome back? When they go from home, when they had a very bad interaction with the families, the last memory has been very unpleasant. So when they want to come back home, their interaction would be based on their last unpleasant interaction. To make that not stick with them, we encourage them to spend time, take them out for a meal. We encourage them, go take them out for a 2-day trip to, say, Bandipur or a Mysore or wherever you want to take them for 2-3 days. Spend time with them. See that they are actually shown the kind of improvement that we have watched. And they become confident. Then gradually they are taught, as Dr. Mathew said, how to cope with them, how to deal with them when they come back home. It does not mean everything will be hunky-dory. It can still have a problem. So they come back and say, we face these issues. This is something which we do pre-discharge. And we tell them how such issues can be handled and coped in a better manner by a more mature understanding interactions. Yes, we do that. It is very essential because we just do not deal with people alone, and the people in the families, because they ultimately belong to the group of families called a unit of the family there.
Thank you, sir. Sir, may I speak? I am Rituparna.
Yes, go ahead.
Yes, sir, I am Rituparna. I am from Tejpur, LGBRIMH. I am doing my PhD on halfway home. So I just wanted to know regarding the institutional caregivers. Do they get any training, sir? Like,
of course.
As sir has mentioned, the family caregivers, they do receive training. But regarding the institutional caregivers, sir, what type of training do they receive to take care of the patient?
When you say institutional caregivers, you mean our staff?
Yes, sir.
Okay.
Yeah.
Now, you are very correct in asking this question because many programs that are run by different colleges, be it social work or psychology, they have very little knowledge or understanding on rehabilitation or chronic mental illness. Their curriculum does not cover this, and they have not seen these people at all before. So when they come to us for the first time, we induct them into some kind of a program by our senior staff to provide the kind of a necessary skills to understand what is chronic mental illness, medication, why medication are important, why is it given, what are the side effects, how to identify that, what kind of a problem these clients face, how do we notice it, how do we help them. So this kind of in-house training that we offer. In fact, Mathew would know very well, We used to run a short-term training program in RFS for 3 months, later 4 months, and later on for 6 months, which was the background on which we started running a 2-year MSc and psychosocial rehabilitation from 1999 to 2015, a 2-year full-time university affiliated master's level program. Unfortunately, due to financial constraints, we had to discontinue the course. Having said that, we have enough experience and wherewithal to provide short-term training for anyone who wants to run rehab programs across the country. In fact, we have people coming to us from different centers for training for 6 months or 6 weeks or 8 weeks, so that they can go back to the centers where they are working as rehab professionals to get the hands-on training. Our training is 50% hands-on. It is just not theory. They have to work with the clients with the help of the senior staff. Stay with us. Learn to be with us 24/7. Do night sleepover duties with them. So it is something that's an ongoing. Rituparna, we would be very happy to have your staff coming and getting trained with us. We'll be delighted to provide such training to you and your team.
Yes. Thank you. Thank you so much, sir.
Good afternoon, sir. I have a question.
Can I just finish a couple of questions that are there in the chat? Because then I will take the questions from the floor. So somebody asks, is there an annual meet day where the participants, that is parents, are allowed to join and witness the feedback from the occupants and patients who utilize the services? So I think there is an annual day. So
Yes.
in fact, every 3 months, Dr. Sundar mentioned.
Yeah. So we have families coming, individual families coming every 3 to 4 months to see their wards. That is done on a one-on basis, one family and one client. And we also have a group of families coming once or twice a year to discuss a common issues concerning rehabilitation of their clients. And they learn from one another how have they been coping, how they can cope. And we provide a kind of support we provide them. And we also have a topic. Some senior professionals or colleagues will come and talk about what is a social skill, what's the brain like in schizophrenia, and what do we do in rehab in different models, as somebody asked. So this kind of a program that we run, in fact, it was being done very regularly until COVID hit us. I think we want to restart such a program where all family members, not only sometimes those who are associated with us, any family member who wants to be part of that, we are welcome. We welcome them to have an interactive session with the families and the staff to understand one another's strength. In fact, we learn a lot from families who have coped with such problems. Sometimes we do not know how to deal with such an issue. Staff have a struggle. A family member will say, when we had a problem like this is how I did it. So it's a mutual learning. It's an extremely strengthening exercise.
Good afternoon, sir. Can I ask you?
Hold on, please. Hold on. Somebody asked, can type of brain waves being produced in the brain be detected? Yes, they can be detected by the EEG, but the EEG is not useful in the treatment because the question also says, can you detect the level of improvement of the personality and how much medicines are required by looking at the EEG? It's not useful to see what treatment should be given, but EEG is studied for different reasons like epilepsy. Admission procedure for long stay patients, I think Sundar has already mentioned.
Yeah, only one point I want to say, because we both run a halfway home and a long stay home, we generally prefer patients coming into the long stay home, which is now currently 17 in number, and we are full. We expect them to go through a halfway home program for at least 6 months to 1 year for us to understand what the problem is, what the individual is like, what's the diagnosis, what are the strengths, what are the problems within the family. To understand the patient and the family, it takes some time. After that, people want to stay in our long stay home. They are asked to give it in writing that they want to move into a long stay facility, and we take them in writing and put them in a waiting room, waiting list. I would also mention now, although our long stay facility is now full, in the current premises that we have, we are planning to have an extended stay home which is essentially a long stay facility, for another 20 to 25 people, which are in the process of starting work on it. And we would be happy to receive, letters. We would happy to receive applications from people who wish to bring their family members for this extended stay facility. We are planning certain policies there. About 20-25 people, both men and women, will be accommodated within our own premises. We're working on it. We hope to have this done within 1 year. We started working on it in 2019 December. Again, sorry to use the word COVID. It's a reality. We put it aside. We put our program back about 2 to 3 years. We have energized now. We want to work on it soon, and we'll be able to provide another 20-25 people long stay facility very soon.
One more question about are the injections available for depression and anxiety? Injections are, most of the time, medicines that are given are oral. Injections are required only if there's an emergency or somebody is not taking medicines. Otherwise, injections are not really required. It's oral medication that's given for schizophrenia, psychosis, depression, anxiety, and so on. But injections are available, which are used only if it needs to be used for some emergency purposes. I think that sort of completes. There are a couple of questions asked by, the technical question actually asked by Dr. Harish, but we'll take that in the end. Let's go to any other. Okay, somebody wanted to ask questions?
Yes.
Go ahead.
Yes, sir. Thank you, sir. Good afternoon, Sundar sir. I'm Murli. My brother, youngest brother, is mentally ill for 35 years. And my mother used to look after him thoroughly, day and night. But now she passed away a couple of years back, and we are looking for a caregiver. We approached a lot of them, but we are not happy with their services. I think you all know that mother can be the best caregiver to her son or a daughter. So why aren't the caregivers trained, or they are willing to provide the services as good as a mother? Is there anything that can be done about this?
A simple question before Sundar answers. Now, I think your brother or sister, whoever it is, probably requires rehabilitation, because my question would be, why cannot the person live on their own? Why does the person require a mother or anybody else? They need to be given the skills to live on their own. If they cannot live on their own, if they fall in this very small 10% category, which requires somebody to look after them all the time, then you're talking about a different thing. So Sundar.
No, I agree with Dr. Mathew, because no mother is going to be permanent, right? So we'll have to look at some family member who can replace that role to provide support. As you said, mother cannot be replaced, but somebody who can provide that kind of a care and compassion and concern must step forward to provide the support. Dr. Mathew also mentioned, is it not possible if the person is on adherence to medication under supervision of a psychiatrist, can it not be monitored and managed and maybe get back to the job? So if those things are not possible by family members, the short stint at rehab, then getting back to the family and the family members providing support. Another advantage of such a patient coming into the rehab is we look at and assess and see amongst 2 siblings, 3 sisters and 1 brother, who is the most caring, compassionate person to provide that support. Some members are not within India, they're outside India. Some sisters who are married, are their spouses willing to support? If the brother is married, is the brother's wife willing to support this individual? So there are a lot of complicating issues. There are no straight answers. Each individual issue, each individual patient's problem has to be assessed in detail, dissected out, and look at all these options. This is what happens when a person comes to rehab. We have the opportunity to work on these matters over a length of time.
Thank you.
As you know, not all siblings are the same. So we'll have to work on that.
Thank you.
Yeah, but also remember, I just want to remind people that as per our laws, Indian laws, it is really the responsibility of the family. The families are the main caretakers and guardians. So no institution, no person can actually take on that role. Legally, family members have to find somebody to take on that role. You can have a legal guardian if there are no family members, but otherwise it's the family's job really. That responsibility cannot be given to any other person or to any other organization.
Thank you.
Any other questions?
So, yeah, sir, my brother is having mental illness from last 22 years, and his one diagnosis is bipolar, and one more diagnosis is recurrent depressive disorder, depression and anxiety. My grandmother had schizophrenia, paranoid schizophrenia, but after the treatment, her improvement was immediately started after ECTs. But in my brother's case, after so many ECTs also, his treatment is his improvement is he's having treatment resistant depression. Doctor is saying like that. So if schizophrenia patients can recover, why it happens? Schizophrenia means schizophrenia considered generally more serious disease than depression. Just want to.
Yeah, so I think simple answer, all human beings are different. All illnesses are different in human beings. One person who has diabetes doesn't behave the same way for another person who has diabetes. So you can't predict these things. So you can't say that, oh, schizophrenia has a serious illness, so people won't get better. Depression is a better illness, so people will get better. There is no such hard and fast rule. Every person is different. So, you really have to assess what is happening and, consult with the doctor, and then the doctor will advise you whether, the illness will recover, how much will recover, whether they are responsive to treatment, not responsive to treatment. All these things can be discussed with the family after the consultation.
Okay, thank you, sir.
Any other questions? Have we covered all the questions in the chat, Sivakumar? If you can.
No, sir.
We have not
A
covered?
couple of questions have not been covered.
Okay, can you read them out?
Yes, sir.
There were a couple of questions which Harish asked, and they might be pertinent here. One is about the Clinical Establishments Act. As per the new Mental Health Care Act and rules coming up in Karnataka, unfortunately, all mental health institutions will also have to follow the Clinical Establishments Act. So that is a bit of a problem, and we are trying to see how to overcome that. We're trying to talk to the Mental Health Authority and see whether something can be done. I know that there's a committee that's been formed with the Director Nimhans as the chairperson to look into these rules. So I think we're still working on that. The other question Dr. Sivakumar asked is about RCI recognition and courses for that. Now, there are again, something which is a little controversial, because the Mental Health Care Act also says that to do mental health care, you have to be registered on the portal for the e-portal for the mental health for the Mental Health Care Act. But the RCI also is something that people might want to register on. So I don't think there are any sort of clear answers yet on these. Everybody who does rehabilitation is not really registered on the RCI, as I know. So I don't know if Sivakumar or anybody else has any better answers to that.
I think recognized institutions offering recognized courses. If they are RCI recognized institution, then you can apply for RCI recognition, RCI number after completing the course. Now you can go to the website and get it done. But as Dr. Mathew said, some of them are very gray areas. Nobody is certain about who gets what done, etc. But RCI recognition is sometimes becomes essential for people to get employed in this care.
Any other questions, Sivakumar, on the chat?
Yeah, I think there is a question by Kusumita Chakrabarti to sir on how to spread the message regarding the advantages of halfway homes in the community. A good proportion of people have no idea about it, firstly, and secondly, they don't want to send family members to the establishment due to stigma.
How to spread? I'm sure some of you, a good number of you are members of the profession, working in different parts of the country. I think you'll have to take the message across. We'll have to talk to the colleges, we'll have to talk to the students, we'll have to talk to the family members groups. We'll have to communicate the right kind of information across media. And if you can take somebody for physiotherapy and rehabilitation of a neuro rehabilitation for a person with a stroke. I think I don't see why you should hesitate to take someone with a brain disease to take to a rehabilitation for recovering from that space. I think we have to come forward and talk about it and take this message forward relentlessly, continuously, and with the correct information, and try to not fall prey into wrong information that may be spread across by different people. We have to be in the forefront as professionals. Family members who have benefited, their voices are better heard, and they should come forward and talk, which can be facilitated by professionals.
I'm going to quickly answer a couple of questions that are there in the chat. Can anybody run a rehab center? The answer, simple answer is no. You need to have registration under the Mental Health Care Act. You need to register the Mental Health Rehab Center. And for that, there are actually very strict guidelines and very strict requirements. There has to be mental health professionals who are, who have to be in charge of them. So anybody, and can old patients run a rehab center? No. The simple answer is no. Unless, of course, they have qualification, they have recognition. Apart from clients who have family members, is there a provision for homeless mentally ill? Now, homeless mentally ill, there are certain facilities, both private and public. Public facility which is available, for example, in Bangalore is, say, for example, if somebody is homeless mentally ill and they're wandering on the street, they are taken to a sort of the colony which is meant for homeless mentally ill. There's a government colony which is there in Bangalore. And many of them are sort of the police or somebody else will pick them up and take them there. And there they're taken care of by the government and with help from the district mental health program psychiatrists who are in charge of that. Somebody says we are giving medicines to somebody without their knowledge. He has partial insight, is not willing to go to rehab. How to make him understand? So, I mean, that is a difficult process, but usually mental health professionals do not recommend giving medicines without their knowledge. This is called a surreptitious medication. It's not really useful. I mean, I know that many people, especially family members, resort to this when there's an acute crisis and they need to get the person to the hospital. But, it's not really recommended. The important thing is to get the person to the mental health professional who's treating, and then to get the person slowly to explain and slowly give insight. It's a long process, but it can be done. Can people from RFS after home go to work and come back in the evening to stay, Dr. Sundar?
Yes, of course. This happened several times. People already have a job. They come to us with a crisis problem. They're not able to cope at home. Once they start getting better, they're able to go to the job and come back. We encourage such things. In fact, we are not trying to collaborate with an organization called Enable India. Enable India has got 16 different wings. They provide support for people with different kinds of disabilities. Recently, they have entered in the space of mental health. So we are trying to connect with Enable India. They do a very fairly exhaustive assessment for people who have good job prospects, who have held jobs before, who had some degrees and some skills. They try to match their skills with the employer. So this process we have just begun. We are hoping to get more people on the bandwagon so that they'll be able to go, work, come back, improve their self-worth and self-confidence, and they'll become earning members. In fact, one of our members used to work with us for an IT company, worked for 6 months, and then he was posted to Switzerland on what they call an on-site. The task was he wanted long-term injectables. How do we make sure he gets the long-term injectable there in the new country? So we wrote a letter. I think it was a collaboration between a Nimhans treating doctor and us at Afi Home at Asha. So we worked together very jointly, gave the letter to the treating doctor in Switzerland, I think, made sure that he continued to take the treatment there. He successfully spent 6 months there and came back. After that, gaining confidence, is living independently and working and earning. So this was possible with the collaborative effort of the treating team outside Richmond Fellowship and the Richmond Fellowship team. So we have a doctor who is with us. He goes half a day to the hospital and works and comes back. He's been with us for 2 years. So this goes on successfully. We in fact encourage such kind of an activity rather than keeping them cooped up here with no other options for them. We try to constantly create options. If there are options, we encourage them to do that.
Somebody is asking what are the charges for a stay period of 6 months. I think if you look at the websites of most of these
Exactly,
software
yes.
homes, you'll find the charges on the website.
Yeah.
And the charges vary depending on how much facilities are provided. So there are some cheaper homes, there are some more expensive homes. Charges actually vary. There's somebody who's asking who to contact when they require training in rehabilitation. I think Richmond Fellowship, even though there are some.
I've given my last slide, I've given
email.
the details, and then I'll be happy to provide for those who want. The email ID is rfsbangalore@gmail.com. RF for Richmond Fellowship Society, Bangalore, one single word, @gmail.com. You write and ask the admin people, will provide a kind of information, and we'll be happy to support this request across the country.
Or you can simply go to the website and look at the details.
Yes, that also is possible. Yes.
Sivakumar, are we done with the questions? I'm seeing that we are at 3:32.
Yes, sir. I think we have satisfactorily, we have
There's
taken up all the
somebody
questions.
somebody is asking in the end about somebody who's got mania and whether they how to take them for treatment. I think that's not really something we can answer here, but essentially I think the person has to be coaxed to go to the hospital. If coaxing does not help, then you'll have to take the help from the police. That's a very simple answer. Or some other, sometimes even in some areas, even the ambulances, the 108 ambulance also might help you to go take the person to the hospital. But basically, if somebody's got an acute illness, you have to take them to the hospital.
And one person has asked whether they can directly approach Enable India.
Well, I suppose so. I mean, I do not know such, what kind of facility they offer. I'm sure you can talk to Enable India. I think they will not deny helping go there. Their accent is to provide support to people with different kinds of disabilities. I think we should approach and we should ask for their help. I'm sure they will be able to at least tell you how to go about getting help. Yes.
I think we have run out of questions, and thank you very much, Dr. Sundar, for a very illuminating session, giving all details. And thank you to all the participants for asking many, many useful and interesting questions. We hope we've managed to answer many of these questions. As Dr. Sivakumar will mention, that this is a regular program that goes on from the Rehab Center in Nimhans. But there are also similar programs that are run for family members by different agencies, whether it's Richmond Fellowship or MPA or other agencies. So please look out for these programs, which might actually be useful to help you in deciding how to care best for your family member who's got a mental illness. Over to Dr. Sivakumar.
Yes.
Before that,
thank you very much.
before Sivakumar winds up, I would like to thank R2R team, Sivakumar and his team in DPNR. I saw Dr. Jagdisha sitting there quietly, the HOD team, and all the members there to do this wonderful, informative, interactive program on varieties of topics, which has been very, very beneficial and useful. And I enjoyed being part of this. And thank you very much, Matthew. Matthew and I have teamed together on several occasions. Once again, team of Matthew and me together today. Thanks, Matthew, for being the chair. And I enjoyed, as he very rightly pointed out, very insightful, very useful, very practical questions. I think people out there are thirsting for knowledge and information. I think it is up to us professionals to try and engage and provide the kind of information the public needs and even the professionals need. A mechanism can be created by the R2R PNR program, how to gather such information, how do we give the answer to people who are asking either for themselves or their family members, or as a professional wanting to help other people. I think the good work that is being done by the DPNR team and the R2R programs should continue to provide such help. Thank you for being part of this. Thank you for asking me to be part of this. Thank you.
Thank you, Sundar. Always a pleasure to join you for anything that you do. I'm also sorry there are many other mental health professionals who joined in online. So I didn't get time to ask all of them because it is very important that we ask the family members and other participants. So I've not specifically been able to ask different people to comment. And we also run out of the time. So back to you, Sivakumar.
Before I forget, the quiet man that Mathew is, he has not talked about something that is coming in the next 2 days. Tomorrow, I think. Tomorrow, 4 o'clock, Dr. Mathew Varghese is giving a talk under the MPA program, which is the Golden Jubilee lecture. Mathew Varghese is going to talk about. Matthew would like to do the talk to the
preventing old age mental disorders.
Yes. Matthew has been a specialist in this area, working on it for over 3 decades plus. He's giving a talk. Those of you would be interested, I think you'll be in for a treat from Matthew tomorrow. Look forward to that, Matthew, tomorrow.
Thank you for the publicity.
Now, see, look, the whole point is our endeavor must be to not to publicize Matthew, publicize the topic, so that people get advantage of experience and expertise that comes across. That's all.
These are meant for public education.
Yeah,
so
exactly.
I'm very keen on that.
Yes.
Thank you.
Thank you, everybody. Sivakumar, on to you.
Yeah, we thank Professor Mathew Varghese for chairing the session and Dr. Kalyanasundaram for having patiently answered all the queries and shared his rich experience. We have recorded the session and the edited link will be soon put up on our Nimhans Rehab YouTube channel. So you can also watch the earlier R2R sessions, which is available on that. And I would also like to thank our head, Dr. Jagdisha, for the mentoring which he has provided to all of us and to our entire team, and specifically to Ms. Agono and Dr. Shaneena, who have actually coordinated this particular session and taken care of all the background work. Thank you very much. In December, we'll be taking a short break. We'll be back with the R2R program on January 2020. Thank you.
Thank you, everybody. Thanks.
Agono, Dr. Shaneena, you can stop the meeting.